So, with all your permission, we are getting started with the session, everyone. Good evening to all. This is Mona Lisa from Team Clarinet, the designated session assistant for the seamless introduction. And Clarinet proudly stands as India's premier digital platform tailored for doctors, providing a wide array of invaluable services. Clarinet is delighted to be chosen as the digital partner for this event organized by Indian Society of Pediatric Neurosurgery. Welcomes you to the webinar on Pediatric Neurooncology III. So thank you for your patient listening, everyone. Let us get started with today's session, for which I would like to call upon Dr. Naveen sir to take the session forward. Over to you, sir.
Thank you, Melissa. Good evening and welcome to all. So as you all know, we are conducting monthly sessions from the Indian Society of Pediatric Neurosurgery on the different subspecialties of pediatric neurosurgery. So we are now continuing with the neuro-oncology sessions, and this is our third session on pediatric neuro-oncology, in which we are covering about the radiation oncology. So we have two eminent speakers, Dr. Sruthi as well as Dr. Debnarayan Dutta, who will be covering the topics about the indications, the basics, and the outcome of radiation oncology. So without wasting much time, I would like to invite Dr. Sruthi, who will be talking to us about the basics of the radiation oncology for pediatric brain tumors. Welcome, Dr. Sruthi. Please, can you start?
Yeah, thank you, Dr. Naveen, for the introduction, and thank you, Dr. Suhas, for giving me this opportunity to talk on this platform. I think radiation oncology as such is a very important topic from the neurosurgery perspective as well. So it forms an important role in the management of any brain tumor protocol. So if we see, is the screen visible, Dr. Naveen?
Yeah, the screen is visible, doctor.
And it's on slideshow mode. 1 second. Yes. So as we all know, pediatric tumors, when we see brain tumors are among the most common solid tumors in the pediatric age group. Even when we see the frequency of pediatric CNS tumors, we see that glial cell tumors, especially pilocytics, are among the commonest, compromising almost around 17.8% of all the CNS tumors, followed by other low-grade gliomas and then ependymal tumors. So if you see in India as well, brain tumors take up to almost around 28.2 incidents per million, so which is quite a huge number. And when you see the protocol for managing these pediatric CNS tumors, you can see that radiation therapy is an important part in treating the same. So if we go through the workflow during this presentation, I expect the students to learn at least the basics of radiation therapy. What are the techniques of radiation? What are the machines we use for delivering radiation? And what are the indications? So this would be my workflow. And when we talk about basics, whenever we talk about radiation, which acts on tumor cells, we talk about ionizing radiation. So this ionizing radiation can act as direct action on the tumor cells, or it can have an indirect action. When we talk about direct action, it means it directly acts on the DNA of the tumor cell. And indirect action means that it can cause free radical damage and indirectly causes DNA. So if you can see here, ionizing radiation, when it occurs as an indirect action, it causes oxygen free radical formation. So this free radical formation in turn causes a p53 independent cellular events, leading to a mitotic catastrophe causing cell death. So this cell death can act in both the tumor cells as well as the normal tissue as well. So both of these damages, the direct action and the indirect action, can occur in both these, the tumor cells and the normal tissue cells. However, you can see that this particular action, whatever we have seen before, this direct and the indirect, is basically for conventional fractionation. Conventional fractionation, what I mean is when the dose per fraction is around 1.8 to around 2.2 gray per fraction. So anything more than this changes is again called different types of fractionation schedules are there. And when we talk about radiosurgery, always the term what we use is called hypofractionation. The word hypofractionation means the dose per fraction is very high. So the mechanism also changes when the dose per fraction changes. So at high doses per fraction, there is something called a ceramide pathway. So this, in the tumor stem cells, the ceramide pathway gets activated, and ceramide, which is a pro-apoptotic molecule, continues to contribute to cell death. So the other part, what we see is the vascular endothelial cells. These vascular endothelial cells always have something called as sphingomyelin. So when the radiation doses, especially the hypofractionated radiation doses are given, this sphingomyelin gets converted into ceramide. And this ceramide, again, being a pro-apoptotic molecule, continues the pathway of apoptosis, leading to tumor cell death. So this is the basic mechanism when we talk about how radiation contributes to cell death. So what kind of ionizing, what are the particles, when we talk about radiation, what are we dealing with? So when we are dealing with something called photons, which can be either gamma rays, which are emitted from the nucleus of a radioactive atom, or by X-rays. So, and the other form of source of radiation therapy are the particle beams. That is the protons, neutrons, and electrons. So whenever we are generally talking about radiation therapy, in the normal parlance, we generally talk about these particular sources of radiation. So as you know, radiation, we discussed that it works by damaging the DNA of cells and destroys their ability to reproduce. So radiation can affect the normal cells and also the cancer cells. But cancer cells have generally an impaired ability to repair this damage, thus leading to cell death. And always when we plan radiation, there is always a tolerance which we need to respect, tolerance of the normal tissue. So beyond which we cannot go. So when we are talking about the radiobiology, how does this radiation act? We also contribute to something called the 4 R's of radiobiology. So these 4 R's of radiobiology mainly deal with repair of sublethal damage and potentially lethal damage. That means whenever you give radiation, unless the damage is lethal damage means there is cell death. But then there is something called sublethal and potentially lethal damage. When you change the microenvironment around the cell, you can reverse this. You can repair these particular damages which happen due to radiation. The next concept in radiation therapy is redistribution of cells within the cell cycle. So many of you know that what are the different parts of the cell cycle is the G1, the G2, the S phase, and the mitotic phase. So usually the most radio-resistant phase would be the S phase, and the most radio-sensitive phase would be the G2M phase. So when we give radiation, there is a redistribution of cells within these cell cycle phases. And we expect the radiation cells to get redistributed within it and come to the radiosensitive phase. The other thing is repopulation of cells between fractions. So what is this concept of fractionation in radiation? Why can't we give the entire dose in one single setting? So there is a RAM model which showed that when you basically when they initially thought that when they give radiation in a single dose, it can cause unnecessary damage to the normal tissue as well, though attaining what is expected to have, the tumor growth can be stopped. But however, we need to balance always the toxicity from the normal tissues and also the tumor control probability. So this comes into place when you give fractionation. So the moment you fractionate the entire dose, you're giving some time for the normal tissue to repopulate, to repair itself and get back to its normalcy. So many of the patients, when they're giving radiation, conventional fractionation, long fractionation especially, we usually tend to give about 5 days a week, and that will go on for around 5 weeks. So in those particular fractionation, people often ask us, why don't you give it on Saturday, Sunday? Why can't it be continued? So that is basically for this normal tissue to get, regenerated, repaired. And Also, the tumor cells don't get repaired so fast as a normal tissue. So the tumor cell death will be there, but normal tissue gets healed. The other thing is reoxygenation. So whenever radiation acts, it usually acts when the hypoxia is less. So when the oxygen content of the tumor is high, the radiation has a maximum effect in those particular tumor cells. So whenever you give radiation, when you give repeated radiation, there is always a reoxygenation process which is happening and which can reoxygenate the tumors and can cause cell death. This is the landmark timeline in radiation oncology when we talk about radiation tumors and radiation in the treatment of tumors. So you can see as early as 1895, we had Röntgen who discovered X-rays. And Marie Curie definitely has a prominent role in radiation therapy for the discovery of radium. And we have continuation of this in terms of improvement in radiation therapy techniques. You can see the ICRP, which has been formed in around 1928. We had cobalt treatment machines coming as early as 1948. And then we had linear accelerators from 1953. And radiation oncology is a continuously evolving field. The treatment machines, the treatment techniques are continuously evolving to provide a very precise dose to the tumor and try to protect the normal tissues as well. So you can see here in the 2D era of radiation therapy, this was the treated area. Say the tumor was this, the normal tissue also was quite significant. But as you come to the 3D era, wherein you have more conformal beams, you can see the treatment of normal tissue has decreased. When you come to the evolution of modern therapy, the present era, when you see IMRT, SBRT techniques, particle beam therapy, again, the dose to the normal tissue has even further reduced. You can see this curve here. This is the curve which shows that you should always have maintained this therapeutic ratio. The TCP should be high. That is, the probability, the tumor control probability should be high, whereas the normal tissue complication probability should be low. So this is the classical graph of therapeutic ratio in radiation oncology. So when you see about tumor, in the tumor, when we talk, we usually have a GTV, which is the gross tumor volume, the CTV, which is the clinical target volume, which usually refers to the microscopic spread of the tumor. So this gross tumor volume is what you can grossly see on the MRI or CT or the contrast CT, whatever you do, you can make out this gross tumor volume. And then you have the CTV, which is the clinical target volume, which actually corresponds to the microscopic tumor spread. Then you have something called the ITV, which is actually the margin given for the motion of the tumor. So this motion is usually not very significant with respect to brain tumors, but with respect to other organs like lung, ITV forms an important role. The other concept is PTV, which is the planning target volume. So the planning target volume is actually the setup margin, which is given for the tumors to account for any setup errors which can happen in the machine. So this concept has evolved over time from the 2D era, wherein only there was a GTV and fields were given accordingly, but then to the present era, wherein you have a GTV, CTV, and a PTV. So this concept is very important: the gross tumor volume, the clinical target volume, and the planning target. Coming to the techniques of radiation therapy, what you need to know is there are different techniques for delivering radiation. So we have already seen 2D, the 3D conformal radiotherapy. IMRT is what is intensity modulated radiotherapy, wherein your normal beam, the modulation and shaping of the beam happens based on the intensity of the beam. Then you have IGRT, which is image guided radiotherapy. That means you're doing a regular imaging process so that you can appropriately see the image and accordingly deliver the treatment as well. You're using an image guidance for delivering radiation. The other technique is VMAT and helical tomotherapy. VMAT is volumetric modulated arc therapy. It's again an arc form of how you're delivering radiation. Then you have helical tomotherapy machines, which deliver radiation in a helical way. It's like a CT bore. I'll just show you the machine as well. This is SRS, that is stereotactic radiosurgery, and stereotactic radiotherapy. So stereotactic radiosurgery means you're giving a single high-dose radiation intracranial. And if you're giving anything between 2 to 5 fractions intracranial, you would call it as stereotactic radiotherapy. The other one is your conventional proton beam therapy. So if you can see this figure, what you can see here is a normal 2D technique. So this is a 2D technique wherein you can see the dose spill off, a significant spill off into the normal tissue. Then comes to your more advanced techniques, wherein you can see the dose conformality is more to the spinal cord. You can see this low dose spillage, which is definitely less as compared to the 2D technique. But if you see this particular technique, the proton technique, you can see how well it is confined only to the target volume. So every technique has its own potential advantages, its limitations, and every technique has to be weighed against both to decide what is best for the patient. So the usual workflow in the department goes like this. You decide the patient needs radiation. The patient gets simulated. That means you're taking the treatment position, how we are going to place the patient, the same way you do a simulation scan with a mask, and then you do image registration, then you fuse whatever available imaging is information you have, you use that. So usually what we do is we fuse the MRI, the T1 contrast and the T2 flare images, and we do a CT and a CT contrast on our CT simulation plan as well. So we fuse all of it, and then the contouring is done. Then the physics team comes into place to do the plan. We have a plan review by the radiation oncologist. We decide if this is a suitable plan for the patient. And then we have a verification, and then the treatment is started. And during the course of treatment also, there is a strict QA procedure for every machine. The quality assurance check is very important. And it again is based on different machines and techniques as well. So this is a kind of a thermoplastic mask. This is the headrest. The patient is placed on the headrest accordingly, and then the mask is made, and this patient is simulated with the mask in place. Then the images are imported. It is registered onto our planning platform. We do the contouring. So usually when you see the contouring, what you do is you draw the GTV if you're seeing the gross tumor. Then you draw the CTV, which is the microscopic tumor spread. Then you draw the PTV, which is the planning target volume to account for the motion setup errors. So this is a kind of field placement, what you can see. This is the 3D kind of field placement where you place different beams and accordingly modify the dose. These are the different machines what we use. These two machines are in our institute. This is a cobalt machine which was used earlier. This is the normal linear accelerator. This is the helical tomotherapy machine which you're seeing here, and this is the CyberKnife. So as we were discussing, there is always a normal tissue tolerance which we need to respect. So in the initial years, there was something called the Imami normal tissue tolerances, which were giving different tolerances for different structures. Now, since volume, we have a quantitative analysis of normal tissue effects in clinic, which gives us volume-based constraints for the organs as well. And now, since we are in the molecular era, we now have an idea as to what all are there, what all are the radiation techniques. We have seen what all are the radiation machines, what is the basics of radiation oncology. You know what is ionizing radiation, what are the particles which are used, what is particle beam therapy. now since we know what basic of radiation, what it is, we need to know where it is used as well. So what are the indications of radiation therapy? Now, since the entire neuro-oncology forum is more about molecular based, even there are certain indications based on molecular pathology as well. You need to optimize your dose. So as you know, low-grade gliomas, high-grade gliomas, brainstem gliomas, ependymoma, medulloblastoma, and ATRT. These are among the commonest pediatric tumors where you usually definitely associate radiation with. So I'll just briefly describe about the indications, and then I think Dr. Dutta will cover more on more techniques on stereotactic radiosurgery, and he'll dwell further into the toxicities as well. So in low-grade glioma, usually you give, especially in an inoperable disease, child more than 3 years, you don't have any other option, then yes. But then if in brainstem low-grade gliomas, if surgery is not possible, yes. And if there is a progressive disease after surgery and chemotherapy in a child less than 3 years with no targetable mutation, then you go. And the dose used is usually around 54 gray over 6 weeks. This is the conventional dose. And what is our target volume? It is usually whatever is the gross disease or whatever is the residue post-surgery plus around 1 centimeter margin. That would be our target volume. So again, post-radiation, you can't expect an immediate shrink sometimes. It takes time, and over time, you can see a response in the tumor control as well. So in high-grade gliomas, you know that the dose needed is slightly higher. You would need around 60 gray. And respecting the normal tissue tolerances, you would stop for brainstem glioma at probably 55.8 gray in around 31 fractions. When you see medulloblastoma, again, there are different subgroups in medulloblastoma, and there are different risk stratification in medulloblastoma as well. So standard risk and high risk, as you know the definitions. In standard risk, we usually have CSI, that is craniospinal irradiation, which is usually given to a dose of around 23.4 gray, which is a reduced dose CSI along with concurrent vincristine, which is being followed now. And in high-risk cases, you would stick to the standard craniospinal radiation of 36 gray, followed by a tumor bed boost of around 55.8 gray. So, and these are our target volumes. We usually target the entire, you can see this is a medulloblastoma case, what we are seeing here. This is the simulation, which is usually prone. In certain pediatric cases, the patient may need anesthesia as well. You always have to ensure that these particular structures are covered completely, because your foramina need to be enclosed into the target volume as well. So all these foramina will be included into our target volume. And we always have a lot of technical issues are there in a craniospinal irradiation. It is one of the most complex procedures in radiation therapy, which needs to be, I'm sticking to the basics because it's a little complex. You should know that radiation therapy is very conformal nowadays. So you can see this is the treatment volume here. You're covering the entire cranial spinal axis here. You can see that the lateral spinal nerve roots are also covered. And you should ensure that the cribriform plate is adequately covered. And especially in the end of the spinal field, you should ensure that the entire thecal sac is also covered in your target volume. So again, this is a prone setup for CSI. This we had already discussed between the proton CSI and the photon CSI. When it comes to ependymoma, again, adjuvant RT is a very plays a very important role. And usually in low-grade ependymomas, you can stick to around 50.4 gray. But then in anaplastic ependymoma, you may go up to 59.4 gray. And again, if there is CSF positivity, you would go ahead with craniospinal irradiation. And in these particular tumors, again, you know that GTV would be your tumor bed, and whatever residual disease you're seeing, CTV would be a 1 to 1.5 centimeter margin and a PTV margin for the same. So I'll end with just a brief glimpse of radiosurgery in role of radiosurgery in pediatric tumors. I think Dr. Dutta will be continuing with this. So in low-grade pilocytics, recurrent low-grade gliomas, craniopharyngiomas, AVM, radiosurgery has a role to play. This was one of our patients who had a very small pilocytic astrocytoma, and we post excision and then presented with recurrent disease, small volume recurrent disease, and we used a 10 gray fractionation for this patient. 2019, the patient was treated with radiation, and in 2022, this is the post-CK 3 years MRI. So I'll end my presentation with this, and I think Dr. Dutta can take over from here for further details.
Hi, Shruthi.
Hi, sir. Hello.
It was a very nice talk. I stuck in Calcutta because of this cyclone. And I'm from it is audible? Yeah, it is audible?
Yeah, it's audible. It's audible.
Yeah. So can I share my screen? Is it possible?
I'll stop sharing.
See, let's make it share. I'm not able to share the screen.
As Dutta is sharing his screen, can I ask you a question?
Yes, please.
So I was just trying to understand. You see, you say repair, isn't it? I mean, and let's say once the radiation is given, you have a repair of normal cells. So what happens in the nervous system? I mean, how much is this so-called repair system working?
So again, whenever
isn't it? We always consider nervous system to be less reparative, isn't it? So I'm just trying to understand the basic again.
Yes. So whatever tissue, even the nervous system, when we talk about, every organ has its own tolerances, as we know. So as long as we respect the radiation tolerance for that particular organ, I think it always has, the normal tissues have the ability to repair itself, as long as we don't exceed the tolerance limit for that particular organ. Once we cross the tolerance limit, the ability to repair gets lost. And definitely radiation has a few toxicities which happen because of radiation, but then they are self-limiting toxicities. That means over the period of time, they can revert back to normalcy, but there are certain toxicities which are again irreparable. So all these, when we are talking about repair of normal tissues, we are talking about how much dose we are giving also. So there is always this concept of potentially lethal damage and sublethal damage. So lethal damage means there is definite cell kill. The cells are irreparable. But potentially lethal and sublethal damage, always we have something called tumor, normal tissue microenvironment. So this microenvironment, when we make it suitable for the tissue to get repaired, to get healed, then the normal tissue also starts, getting repaired as well. Even in nervous system, when we talk about the glial tissue, the glial cells also have an ability to heal, because that is how we are able to give this particular dose to the central nervous system tumors as well. But then suppose we give around 60 gray dose to the brainstem area, like complete brainstem, say a diffuse brainstem glioma is there, we are unable to give 60 gray because the entire brainstem cannot tolerate that much dose.
Yeah.
So always this balance of the tumor control, the normal tissue complication probability always needs to keep balanced, so that we can achieve a complete
little help from you. I have already followed the presentation. Is it possible to download it? Because I'm not able to share it.
Sure, I'll do that.
Share it and take it up from there. And I have a question also. Now, it is really interesting that nervous cells don't regenerate.
I mean, yeah, that is the normal, isn't it? Yeah.
No. So if you give radiations, they will damage and it will never get repaired. So how the normal cells give radiation getting repaired? Actually, the nervous cells never get repaired. It is the glial cells which is repaired. So it is there is some.
Yeah, you mean the primary neuron does not get regenerated.
Primary neurons never. So whatever the damage happens because of radiation to normal tissue is a permanent one. So they keep the memory. And so there is a lifetime amount of dose you can give. Only the glial cells, which are supporting cells to the neurons, they regenerate. When you're giving radiations, these tumor cells die and these supporting cells regenerate. They help the neuronal cells to myelinate again when they demyelinate after the radiations, and then the functions slowly get adjusted, adapted, and some others area of the brain take their functions which is got damaged. So the neuronal cell does not get damaged. So it's really interesting. So how the brain works and the head and neck works is a completely different. I mean, head and neck radiations, normal cells repair.
Yeah.
In neuron cells, the normal cells never repair. It's only the supportive cells which help us to remyelination and the functions to other area of the brain. So it is our perception about radiation in brain tumors are a little tricky.
Yeah.
That is one of the reasons why the proton is coming, because of less damage to the normal cells, because it's not able to repair it. Cyberknife is coming, or we always try to focus and more focus kind of radiations, because whatever this dose spillage happens to the normal tissue, it is a permanent damage. It is not repairable. So even if it 10%, 15% dose we can reduce to other areas, it is really going to be useful.
I think Shruti is sharing the screen. Yeah.
And Shruti, can you do me one small favor? You can share the slides. See,
you can run it.
We had a talk about the basic of radiations. Now I'll try to share some of the different types of radiations and what is the benefit of those radiations. And then in the second talk, I'm going to share about the outcomes and toxicities of pediatric tumors treated with radiation therapy, what we had just had a discussion. So we'll put it in that way. Now, Sruthi, can you put the next slide, please? Now, when you talk about radiation therapy, there are two aspects. Normal radiations, what Dr. Sruthi has already told, and something called little high precision radiation called radiosurgery. And as Dr. Sruthi has already had a talk about a normal kind of radiations, like tomotherapy, linear accelerators, let's do some focus on indications which are radiosurgery kind, because that is also something new. And I think many of the students are there who have no clue about the radiosurgery and should know, because you people actually are going to use it more often than us. Now, when we talk about indications for radiosurgery, there are two aspects. Two means four aspects actually. One is the benign brain tumors like acoustic schwannomas, glomus tumors, pituitary tumors. Now, interesting thing is that you need to give a very low dose, 12 to 15 gray in this. And if you increase the dose, it does not help. And it takes a long time to see the response. And usually these patients live long. So the toxicity is paramount. So in this group of tumors, what we treat with radiation therapy. Next. Now the second group is the vascular lesions like AVMs, hemangiomas, cavernomas. They are a completely different type of disease where we relatively higher dose we give. Then other benign tumors we give up to 12 to 15. Here we give around 18 to 20 gray. So little higher dose than the benign tumors we give. And there is a response, and response usually take 2 to 3 years. And there is a definitive response what you get, not like benign disease, like lack of progression. I mean, it is not increasing. We call it response. It is not like that. Here we see a regression and complete response and obliteration at some point of time, 3 years to 5 years down the line after the radiation is given, is considered as a response. So here a definitive response assessment measures are important, and you need to give this kind of dose. Next. Another is a malignant tumors, like brain metastasis, like recurrent gliomas, where we need to give very high dose, like 20 gray, 24 gray single fractions, many times 30 gray in 5 fractions. So we need to give very high dose of radiations in this group of patients, where it is a malignant tumors. Dose escalation helps in this group of patients. These patients live usually for 1 to 2 years. So radiological response is important and toxicity is also important. And there is a definitive response assessment criteria for this patient group. And the fourth one, and the last one, and a very interesting one, is a functional indications, like those patients who are treated with, like trigeminal neuralgias, epilepsy, movement disorders. Here, the total dose is 150 to 170 gray, means extremely high dose of radiations. And these patients are normal patients. They live long, and the toxicity is paramount. So in those patients, we need to be doubly sure before you do the radiation in those patient group. And symptom-free is important. We don't have any radiological assessment tool to assess the response. So it is the symptom assessment which is important in this patient cohort. So we need to do it in that way. Next. So the approach, the assessment, all will depend on the kind of treatment what we are doing. Now, I think you people will be not confused about what is called radiosurgery, SRS, what is called SBRT, what is called SABR. There's a really so much of confusion in the text also, when you're talking also, when you're reporting also. Now, interesting thing is that it means a single fraction radiations, mostly used in gamma knife in 1950s and 60s time. SBRT is a multiple fraction radiation treated in extracranial side, like linear accelerator based treatment for prostate, for lung, for liver, something like that. Now, many times what we are doing since 2011, this terminology has come, that many times in brain also we are treating it fractionated regimen, and many times in extracranial site also we are treating in single fractions. So the SRS or SBRT is sometimes interchangeable. Means in brain, if you're doing 30 gray in 5 fractions, that is like an SBRT. In spine, when you're doing 24 gray in single fraction, that is like SRS. So to take into account these confusions and make it clear, it is a SABR. Means if the dose is more than 6 gray, irrespective of it is multiple fractions, single fractions, brain or extracranial site, we call it SABR. So the nomenclature for SRS for SBRT is gone. Now we call it SABR for all our patients where the dose is more than 6 gray per fractions. So this is the nomenclature now, and I think this is really so much confusion that need to be taken care of. Now, when it call it stereotactic radiosurgery, there is also a huge misnomer in that. The main misnomer is that that about stereotactic. What stereotactic? There is no stereotactic now. Earlier, when we used to put a frame, we call it stereotactic radiotherapy. But now, as there is no frame, we don't call it a stereotactic radiotherapy. Now it is all radiological based. Now, for cyber knife, in fact for linear axis true beam also, what is done is a scan done. You match the scan, MRI scan or CT scan, and then treat. There is no stereotaxy, no fixation. It is the machines with the fixation device. What we do is mostly a simple frame, simple mask. What we use, not a fixed frame. What is used is shown in this picture. So the stereotaxy nomenclature is also a misnomer now. It is now a stereotactic is misnomer. We call it image guided radiosurgery. Image guided SABR. That should be the nomenclature now. Next. So this is what we do. We match it and then treat it. Next. Now, in a radiosurgery for brain disease, what is the workflow? We select a case, we proper immobilization. In a gamma knife setting, we do a fixed frame. In linear accelerator or cyber knife kind of setting, we use either like this a double mask frame, which is useful, and immobilization is much better than a single based mask. And then you do an MRI, do a CT scan, you fuse it, and then treat. And the treatment is done, and the planning is done, contouring is done, and treatment is done on the second day, usually. Next. So, not like not like gamma knife or like where the treatment is done in a single day. Here, the treatment is done in 2 days. 1 day is for preparing the patient and next day for delivering the treatment. So it becomes more comfortable for the patient. So when you talk about the radiosurgery tools, there are gamma knife, the linear invasive brain lab, Novali, Triology, CyberKnife. So many things are there. I'll just, because it is something new for the students, we will have a small discussion about it. Next. Next, yeah. So this is a gamma knife, and I think Dr. Sruthi has already told about it. This is a brain lab system. Next, brain lab. Brain lab system in 1990s, and where it is a linear accelerator based fixed frame with a 5 millimeter MLCs. We used to treat the brain lesions with radio surgery, and my fellowship is done in brain lab system only from Tata Memorial. Next. This is how in brain lab also used to put a fixed frame like gamma knife. Next. I'll see this is how we put the frame, and putting frame is usually done by the neurosurgeons, but many places the radiation oncologists also do, like in Tata Memorial we used to do ourselves. These are the screws, and this screws has a little unique kind of screws which we use so that there is an anti-torque. So you cannot put more than a point, it will get stuck. Next. To prevent it should not go into the brain. And next. See, this is how you put a localizer frame. That is called a stereotactic frame. So it is a localizer frame which is used, and based on the localizer frame, we where the tumor is and treat. So that is the reason why it is called stereotactic radiotherapy. Next, and the scan is done. These are DSAs. In CT scan, the angiography is done, and then we match it. And next CT scan is done. Then we plan it in the brain lab system. It was a little crude, but it was okay. It is called something called Lutz test. We used to do the isocentric accuracy of the machine and the treatment position. So this Lutz test need to be done. Next. This is after the treatment, we used to open up the box. You can see the Lutz test, that photographs, and I think if people have been in any gamma knife center, they also do the same thing. They put the Lutz test things, and we unblock these screws. And next, sometimes we see like that. It is one of my patients there when I was in Tata Memorial. This kind of, and it happens in 10%. Subdural hematoma is common, usually asymptomatic in most of the patients, but 10% of the patients have a subdural kind of hematoma. Next. So then came the stereotactic frame based, means double mask frame, where you don't need to put a screw. And that is called brain lab SCRT frame, where you can do up to fractionations, not a single fraction. You can do up to 5 fractions, sometimes more than that also, kind of radiations. Next. This is the frame, and you have to put the patient like that, positioning the patient. Next. And then make the mask. Is the double frame, so we have a mouth bite so that the rotational error is taken care of. Next. Yeah, then this is how we used to put, and then you treat. This is the Lutz test, isocentric accuracy is done in this patient, and you can see the Lutz test, you can see the parameters. So, and then came the CyberKnife system. So in the CyberKnife system, what happens? This is also a radiosurgery system, but it is a dedicated radiosurgery system. You cannot do a normal radiation in CyberKnife. It has to be done, only radiosurgery can be done with that. So there is a 2 aspect of radiosurgery. One is it is high precision, because it can treat a moving target also. In the brain, it can track it and treat it. Even in the brain, there is a movement that need to be taken into account. And other is hypofractional treatment. Short course treatment you need to do. You need to give a higher BED, like in brain metastases, or in a high-grade recurrent high-grade glioma, where you want to give higher dose. That is why the CyberKnife system actually has an edge over others, and it has been made for that. Next. This is the machine, and I think many people have not seen. It is a robot which is attached to an industrial robot attached to a linear accelerator. This industrial robot is used for making a car. You can see in a lot of videos in the YouTube where this robot is used for making cars. So the same robot is used. It has 6 levers, and all the 6 levers have a different functions. So then the error is much lesser. This is the imaging system. There's a tracking system there, and these are detectors which from there the source can come, and we can. So it has a two X-rays 90-degree apart from each other. If you take an X-ray 90-degree apart from each other, as a physics point of view, you actually can correct the rotational error as well. So it has its own advantage. Yeah. Yeah, Sruthi, hello.
It looks like she got disconnected or what?
Yeah, I think Sruthi got disconnected. I think she will be back. So it has some real unique advantage of tracking the thing. And when you talk about radiotherapy, there are different tools, and over the years there are a lot of improvement, a lot of refinement has happened, and this is one kind of refinement that is there. And now there is a proton therapy actually has come in. The ZAP system has come in, which also has its advantage of treating in an appropriate manner.
Yeah, she's starting again. Yeah.
So this is coming. Yeah. So this is the positioning of the patient. Next is all the Apollo pictures. So we will go fast. Next. Yeah.
Can you make it full screen, Sruthi? Make it full screen, please. Yeah, thank you.
Yeah. So now gamma knife and cyber knife. All has done this should be treated with gamma knife. This treated with cyber knife. And I know that the students are very much confused whether we should treat with gamma knife or cyber knife. Now, gamma knife and cyber knife actually are almost same. There are principles of beam arrangements are same. Dose distribution parameters are same. Multiple isocenters are there in gamma knife and cyber knife. Treatment delivery accuracies are same. And both can treat the single fractions and intracranial indications. These are same. So there are, actually gamma knife is a LED version of black and white TV. So when you talk about black and white TV, it gives us as a picture. LED TV also gives us a picture, but LED TV is a automated, computerized, more advanced form because of the time we have able to incorporate new advances there. But it has been based on the black and white TV, and the black and white TV is in 1960s gamma knife, where it is little crude, but this is the base for for the cyber knife. So the inventor of cyber knife and gamma knife have a very good liaison. They have taken into account all the good things of gamma knife there. But there are a lot of dissimilarities also. It's not same as well. Like in the gamma knife, it is a cobalt source. In cyber knife, it is a linear accelerator source. So we know that cobalt source need to be replaced and has a penumbra, has its own disadvantages of radiation changes. So if you switch off, linear accelerator is off, so there is no radiation hazard. In gamma knife, there are 201 sources, and these sources are always active. So chance of hazards is much more. And if there's any leaf is open, even during the treatment, it can cause huge amount of exposure radiation. Whereas in cyber knife, the chance of errors are much lesser because if you switch off, there's no radiation there. So there's no hazard in that case. There's an inverse planning system in cyber knife, which is multi-plan what we do, which is not there. Gamma knife planning system is a little more less complex. It can be done in the planning system, and I think those people have seen the gamma knife know that we can plan it and treat it immediately. So it is less complex, and it has been made less complex for the neurosurgeons to use it, and not a lot of radiobiology involved in that. It is, and we usually use it 50% isodose. So inside it is hot, whereas cyber knife is like linear accelerator kind, where we prescribe at 80 to 85% isodose. So dose homogeneity is more with cyber knife, and inhomogeneity is more with gamma knife. Both have its own advantage and disadvantage, and depending on the indications, we can do it. Cyber knife is multiple and single both. Gamma knife is mostly single. Now there are some new machines has come, and Flexons and Perplex, which actually can use multiple fractions, but then they don't use a fixed prime. They use a mask, which is like cyber knife. So it becomes more similar to cyber knife than the older gamma knife system in that. And verification is not possible with gamma knife because there is no radiation verification system available there. In cyber knife, it is available. And in gamma knife, it is only for the brain, and CyberKnife is for brain and extracranial sites as well. So both has its own advantage and disadvantage. And CyberKnife actually has taken all the goods about gamma knife and added something more which is available as of now. Next. So this is a plan which where 20 gray in single fraction is done, like gamma knife. And if you see the prescription actual dose is 50%. So you can see the dose. Next. Now this patient is like CyberKnife treated, same 20 gray in single fractions, but prescription is 95% actual dose. Next. Now you see that there's now I think for the people you will not be able to understand. They see if you see the picture, if you treat it's CyberKnife kind, then the dose spill off is little more, but hotspot is less. In gamma knife, dose spill off is less, but hotspot is more. Some areas like benign tumors, where we don't want too much of hotspot inside, there CyberKnife may be useful because we don't want to have necrosis inside. Whereas when we are treating a brain metastasis or we are treating a high-grade glioma, where we want an inside high dose, in that case, gamma knife has an advantage. Our gamma knife kind of plan has an advantage compared to CyberKnife kind or linear accelerator kind. Next. So I'll go a little fast. Next. Next. This is different. So they are different and they are next. Now, based on the CyberKnife and gamma knife, so next one slide before. One slide before. Yeah, this one. So based on the CyberKnife and gamma knife, now the radiobiology actually has proposed a classification. Like if it is a gamma knife based SABR or SBRT or SRS, it called GSABR. Linear accelerator is LSAR. CyberKnife is CSABR. Tomotherapy, because though those machines are treating with same kind of dose, but dose distribution is not same. They have a different kind of radiobiology, so the outcome cannot be same. So when we compare a gamma knife and CyberKnife, it should not be compared like that because they both have a different kind of radiobiology, different kind of dose distribution. So the toxicity, the outcome is definitely going to be different. So ideally, you should compare CyberKnife kind of system with CyberKnife, gamma knife system with gamma knife. So I think that is something new that has happened. Now, we'll skip few things, like I think Dr. Sruthi has already told about we need to have a good CT scan. Now, when we talk about this radiation facility, what actually happens, we need to do an MRI, PET scan, we need to do is that. Ultimately, we are treating on CT scan. So we need to do an appropriate CT scan. If you don't do a proper planning scan and don't have a proper MRI, we will not just see this. This one is not a reconstruction image because it is a thick slice. So reconstruction images are so bad. Now, see, this is a thin slice. You can see the reconstruction. When you do the contour, like surgeons, we also see not only axial, we see on sagittal and coronal as well. So there you need to see it well. So many times you do a double contrast. If you do a double contrast, then you can see the lesions well. Next. So standardization, so if you just window level, if you change, the volume also changes. So there should be standardized window level before you treat. Now there is a metallic artifact, especially if there is some artifact in there, you put a একটু রাখো আমি একটু শেষ করে একটু দেখো Now there's a metallic artifact. If it is a metallic artifact there, and like if you put a like ABM, you put a embolization is done, or the dental artifact, you can see the artifact. You cannot treat without a metallic artifact reduction. Next, you see. Same patient, when you do a metallic artifact reduction, you can you can see so well. You can see it better. And if you are not able to see it better, you cannot contour it or you cannot plan it well. So in radiation, it is not about doing the dose, or it is about so many factors which actually gives a better results. We have to have a proper scan in a proper method, proper immobilization, and proper methods so that we can contour it well. So it is important. See, now this image fusion also is important. So if you're not able to do the fusions properly, putting the position in the same place, same kind of position like MRI and CT scan, you cannot treat it well. So radiation is also mostly depend on the user, like surgeons. Like if a surgeon is know how to approach and do a surgery, radiation also is like that. It's not the machine which treats. We have to position the patient and appropriately. Then only the dose what you're delivering will be delivered well. I think Dr. Sruthi has told about the tolerance. There is a standard format for dose calculation, predicting the complications and predicting how the patient is going to behave after the treatment. So these are all predictive models which is there. And based on that, we can do. This is the PTV margins, how we put. There are different criteria as well. So now when we see the response, I think now neurosurgeons are important because the patients go to them for response assessment. If you see in a renal cell cancer, if you do a assessment after the treatment, there is not much shrink. It remains almost stable. So we call it response. Whereas in a breast cancer, when you do a same 20 single fraction dose, there's a significant shrink in this tumor. So we call it response. But we know that renal cell cancer, even if there's a brain metastasis like this, they will live long because the response is sustained. It is going to be sustained for a long time. Whereas in a breast cancer with metastasis, that will not be sustained. New lesions are going to come over the period of time. So the response is not the only criteria for predicting the outcome, overall survival. Like this, if you see a acoustic schwannoma, you can see there's a baseline, then the 2 years, there is a central necrosis. So may not have shrunk in size, but central necrosis there. At 4 years, there we can see it. So benign tumors need longer period of time to shrink. Like if you see the acoustic schwannoma in Kondanjulka paper, if you see at 5 or 6 years, 80% of the patient have regression. On the same time, if you see 1 or 2 years, only 30 or 40% people have response regression. So for benign tumors, we need to wait for, and actually 5% of the patient have an increase in size in acoustic schwannoma. So we cannot tell that there is a response to treatment in 1 or 2 years. We have to wait for 3 to 4 years or more 5 years to see the shrink. And 70 to 80% of the patients are going to shrink acoustic schwannomas, meningiomas, or if you have a 5 years follow-up in those patients. Next. Now see the response assessment also. Now this was the thing, and meningiomas, and after 3 years, we can see a response. So we have to wait longer period to have a response. Like this one is a brain metastasis from a breast primary. See, this is a response happened in 2018. Next. See, this is another patient which is having a thing which has a response at 6 months times. Next. See, but then it has started increasing again. At 8 months time, you see the lesion has started increasing. Next. See, now it has increased, but the character has changed. It is like a necrosis. It is not a, so pseudo progression is also important. That need to be taken into account. Next. 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 So you can see the pseudo progressions are there, and next. So it is important to see, and the radiation toxicities are also depending on the 12 gray volume. And so there is a specific criteria to see, these are the dose response. See, now if you give 25 gray in 5 fractions, now it is really interesting, and neurosurgeons should know that if you are giving 25 in 5 like this, then the response rate is only 56%, but radiation necrosis is 4% only. But if you give 9 gray in 3 fractions or 24 gray in single fractions, then response is 90%, but the radiation necrosis risk is around 9 to 10%. So you take that chance of radiation necrosis about 10%, where only 2 to 3% are symptomatic, 8% are asymptomatic. Only radiological, there is radiation necrosis, but the response rate is 80 to 90%. Moment you become a little colder, means you give only 25 gray in 5 fractions, then you will not see the response. The response is only 50 to 60%. So you see, I think Dr. Shuhas will agree that many times in our tumor board, we always push for single fraction high dose radiation for brain metastasis, because, and we accept that radiation necrosis to some extent. in those. So it is a to accept some kind of radiation necrosis, but not compromise on the response to the treatment. Next, this is like same thing. Next. We can, yeah. So this is a plot to see that how it works out. So next. So next. Yeah. So you see that when when you talk about radiation, especially very high dose, high precision kind of radiation, which is really used and very commonly used in brain tumors, like radiosurgery kind, and it can be gamma knife based or radiosurgery based with tomotherapy, or cyber knife, linear accelerators. So they have a 50 years follow for these patients with gamma knife, and there are multiple prospective studies are there. Contouring is very important aspects, and as you can see, it is a treatment delivery which is also very much important, and how you deliver the dose, like the surgery. It is expertise how you deliver the surgery. Same thing actually happens for radiation also. So it is important to precisely deliver, and it's important to know these small aspects of radiation therapy if we are able to have a good outcome for these patients. Thank you. I think it was useful to Dr. Suhas.
Yeah, I think it's complicated, of course, but at the same time useful. Yeah. Naveen, you want to say something? One question is there in that box. You can ask for it, maybe.
Yeah. I think there's one question in the chat box, that how do you differentiate between radionecrosis versus pseudoprogression versus recurrence?
Yeah, it is really complicated, and see, usually if you do a methionine PET level to try to differentiate between that, because radiation necrosis is not going to pick up, but methionine PET is going to pick up. But that also has its own issues. Usually, what happens if you do a spectro and find out there's a radiation necrosis, that lipid lactate peak is there, you consider it as a radiation necrosis. But if you see there's a choline peak, then you consider it as a recurrence. So it depends on the spectro finding, proper MR finding, and a follow-up. Sometimes we don't know. We do a 3 months follow-up and see whether it is increasing or it is decreasing. If the edema and the nature of the contrast enhancement is changing, we can consider it as a radiation necrosis. So it is really complicated, but with experience, slowly we know that how we can. Most of the time, if the patient is a radiation necrosis, they do well. If the patient is fit and fine, and radiology pictures are showing an ugly lesion, most time we consider it as a radiation necrosis. On the other hand, if the patient is not well, then we see that the disease has started progressing, and that is why the patient is not doing well.
Yeah, I think if all the centers do not have PET, I think perfusion scan in MRI can also be helpful.
Yeah. Perfusion scan is a hyperperfused will happen in necrosis, hyperperfused in neck recurrence. Because sometimes what happens, the recurrence is very small, and the voxel for the spectrum or perfusion is tricky. And if it is not in the right place, if it is extremely difficult to sometimes to differentiate between that. But that is the best option what we have now. Most of the time, we add the clinical inputs as well, and we put in the tumor board, and it is the clinical data, radiological data, and the nature of the disease. What is the type of disease? And that actually helps to find out whether it is radiation necrosis or recurrence.
Yeah, by my clinical data, you mean if it's a highly malignant tumor, you expect recurrence as the highest possible. I mean,
it's a radiation RCC with a showing little increase in size. We call it radiation necrosis, but it's the breast cancer which has a multiple lung metastasis, liver metastasis, and increase in size. We call it a radiation is recurrence only.
Hello. So I have a question. This is Praneeth. So Gamma Knife Icon, now it has got inversion planning, and we don't have much to plan, just to define that. I have a question that would you be comfortable planning the isodence line at 50% or 95% for brain tumors when you are dealing with sensitive structures around?
Yeah, it is really interesting. See, now Icon actually is planning with the mask, and a inverse planning system. So they have copied the CyberKnife system. So in the CyberKnife, what we do, we put a mask planning system, and we put multiple isocenters. Now the icon is actually like CyberKnife only, and there's not much difference between that. So as we are putting a mask, not a fixed frame, the accuracy, which was the key for the gamma knife, that is a little blurred with compared to that. But if you consider the treatment time with gamma knife, I think those people are using gamma knife, they know it takes 1.5, 2 hours, 3 hours for the treatment, because you have to change the position, change the thing, change the different apertures you have to use, and it takes little longer time. On the other hand, it is easy to treat with CyberKnife because the treatment time is not more than 30 minutes. And the modern M6 or M7 is around, they take much lesser time than that. Now, when you treat with a 50% isodose line, we are giving a very high dose inside. I'll be very comfortable in brain metastasis, in recurrent, but I'm not that comfortable in acoustic schwannomas or meningiomas. You know, if you give 12 gray for a acoustic schwannoma, it is the 13% isodose line, 13 gray isodose line, which actually predicts the necrosis. And it has been already proven that if you give a more than 5% of more than 13 gray, then the chance of radiation necrosis is higher. And these patients have radiation changes, and symptomatic radiation necrosis actually happens. So usually in benign tumors, I'll be very comfortable in treating in 90% isodose line. In malignant tumors, we want to treat in a lower isodose, like 50% isodose.
So if I can share you practice at AIIMS Delhi, we are still using a frame for single fraction. Only when we are using multiple fraction with icon, we are using mask just for the consumables and everything else. Sir, I have one more question. Are you?
You agree with me? You agree with me about the gamma knife? My observations. Now you have seen some gamma knife thing, right?
Yes, sir. Well, neurosurgeon will be happy seeing necrosis unless there is no associated edema, because once the necrosis settles, the tumor starts to shrink, as you have already shown in your observation. But as of now, we are using gamma knife for benign lesions, for gliomas and everything. We see a very good response, but we are always bothered about spillage when we plan at 95% isodose, and gamma knife won't usually allow, because of the safety margins. It has only 50% planning as of now. Yeah. So one more question, sir. Do you really advise for proton therapy in small children, 2 years, 3 years, with brain tumors?
See, my next talk, we don't have time. We have
sure, sir.
It's interesting, but interesting. See, next meeting should be on proton therapies and for pediatric tumors. See, this is spillage. What you're talking about is a USP for proton, because there is not much spillage, because there is no exit dose. So it becomes so easy to treat with proton in a pediatric patients. Now, if in a pediatric patient, the most important factor should be 25 years survival, not a 5-year survival. And when we talk about this long-term, but very long-term survival, 20-25 years survival, because in a medulloblastoma, we know that 10 years survival is around 80%. But what is the 25-year survival? What is the 30-year survival? Because these patients are 10 years, 15 years when we treat. So we expect a 25-30-year survival in that. That is around 30%. You know why? Because of the toxicity of treatment, not because of the disease. Because disease is controlled at 5 years or 10 years. It is the radiation toxicity that sets in at after 10 years. And these patients have so much of complications there. So pediatric patients, the proton or precision radiation therapy, means high precision radiation therapy, like CyberKnife also, where the dose spillage is less and the normal tissue get less dose, is critical. And that need to be evaluated, because it is not about only controlling the disease, it is controlling the long-term outcome. Many times we don't see a 25 years follow-up. We just ignore it. 5 years, 80% survival, we are happy. But same patients, if you follow for long-term, then we know that what good or bad we have done for the patients. There, it is not about the control alone. It is they are back to normal life. They should have a child. They should marry. they should have a proper job. That is the success. It is not about the disease, controlling the disease is important. So that is where proton therapy comes into the picture. And I think slowly in pediatric tumors, we should treat with something which is very precise, like cyberknife or proton therapy. If it is too small, then we can go with cyberknife. It's a little bit like CSI or something like that, or a large area of the brain we are treating, then we should treat with proton.
Dutta, I agree that your last few comments were extremely philosophical, actually. If you look at radiation versus child versus neuro-oncology and neurosurgery, what you said last was probably the most crucial striking point. But I'll ask you one practical question. Now, if you say that the radiation toxicities can keep continuing, how long do you want them to be radiologically followed?
See, problem is the radiological follow-up.
Not for the tumor, radiological follow-up post-radiation.
See, radiological follow-up is for different reason. So first 5 or 10 years, we see for the recurrence. After that, we see
tumor, keep it separate. I'm not interested in neuro-oncology, let's say after 10 years. After that, what?
After the second malignancy, there has to be seen for second malignancy as well. So the risk is very low, but it is a real risk. So when a 10-year-old or 15-year-old boy is getting radiations and 35, 40 years, there is a risk of radiation related malignancy, like gliomas or meningiomas are there. We should be able to treat them early, to pick up them early. It may not be every year. It be every 5 years also. If we do that, then our main intent is to just see the radiation-related malignancy after 10 years. So it can be every 5 years also. Follow-up scan will be okay. Then we are able to pick it up early. Most of the time,
do we have a protocol?
We do have a protocol, and the US actually have a protocol. They follow this first 10 years. First 5 years is they have a standard follow-up. Then once in a year.
Yeah. After 10 years, what's the protocol?
Every 3 years they ask for, because of if you ask for 5 years, they may forget to take the scan as well, because they are not they're doing well. They're not. So every 3 years, actual recommendation to see the doctor, find out any issues. Many times these meningiomas are low-grade gliomas are asymptomatic. So we need to do a scan to find it out if it is there or not.
And what about the vascular issues?
Every 3 years.
Vascular issues?
Vascular issues also there, but vascular is a cause symptom. Most of the time, it is, see, any kind of vascular event, they will have a event. You will be able to know. And if it is not causing event, then it is not important for us as well. But if only atherosclerosis is not important. Atherosclerosis causing...
I'm talking about moya-moya.
Moya-moya disease will cause symptom. Moya-moya usually happens for 6 months after radiation. Usually you don't see moya-moya disease at 10 years after the radiations. It is usually acute symptoms, acute radiation toxicity.
Craniopharyngioma, I mean, let's say child treated with craniopharyngioma, how long do you expect moya-moya?
We do expect.
How long? How far? How far?
Past 6 months or 1 year, because see, I have seen only 2 moya-moya disease in my last 15 years of treating neuro-oncology. So these patients actually happened in first 6 months after radiations, because moya-moya disease is known for acute vasculitis. So they are expected to happen early. But problem is when you give radiations, there is the internal carotid artery, especially if you are treating the cavernous sinus, the internal carotid arteries, they get sclerosed. And then this risk of infarct is much higher than others. It is extremely difficult to predict it, but we know that there is a sclerosis that happens.
Angio is indicated. Without
prophylactic is
for the evaluation. Yeah.
Evaluations, it is not. I don't know, because see, in Michael Breda is one of the authority of treating this, finding out these patients who have a brain infarct after the radiation. And there's no guideline for doing a prophylactic angio, but now we have a CT angio, non-invasive. They actually can predict it. Maybe it was not there when Dr. Breda did this work, but now I think we should think about CT angio, where we can find out the atherosclerotic plaques and all.
Yeah.
Yeah.
Yeah, I think we can close, isn't it?
I think. Yeah.
You have any comments?
No, I think it has been a very good lecture from both of them. I think he added a very valid point, like proton, which is coming up for the childhood cancers. Maybe we can have a small add-on session if something else is required in the neuro-oncology, so that will be good for the new residents. Nah?
Absolutely.
We'll do that. We'll do that.
Radiation oncology, I think, is a very vast subject to, cover in one session. So, and even toxicities, I think it's a totally different topic altogether.
Yeah, I think we can have both of them, like toxicity as well as. But I think we think we should thank Dr. Shruthi and Dr. Debnarayan. They have covered the topic very well. I think they have cleared the basic concepts that what is IMRT, what is SRS, SBRT. So I think they have a lot of confusion about that.
Yeah.
So thank you, Dr. Shruthi and Dr. Debnarayan, and you have been a good session for all of us, I suppose.
Thank you for the opportunity.
First talk, I thought that we should talk about the IMRT only, names.
Yeah.
So what we'll do is the next sessions, along with the tumors, we will bring you so that you can talk about those specific tumors and their treatment strategy as specific. Naveen, can I close it, Naveen?
Yeah, I think we
yeah. So for all the residents who are there, the sessions would be available in the our YouTube channel, and you can go into that and get more, of course, have a detailed view of it. And the next class would be on spinal extradural tumors and spinal intramedullary. And I think you should all become a part of the Industrian family so that you get all the membership details and all such details of. I thank my colleague, Dr. Naveen, and the faculty again for joining us. Thank you. Thank you, everybody.
Thank you. Good night.
Thanks. Good night. Thank you.
With that, we come to the conclusion, everyone. Thank you so much for letting us host the session today. I hope you all had a seamless and hassle-free experience. So with all your last comment, we are concluding the session over here and really looking forward to hosting all again. Thank you so much, everyone, and you all can leave now.